Hello everyone, welcome back. Today I'll be covering approach to acute non-traumatic joint condition. Started off with history, physical examination, blood investigation, radiological investigation, differential diagnosis. In summary, inflammatory causes include rheumatoid disease, systemic lupus erythematosus (SLE), Scleroderma, polymyositis, rheumatic fever, juvenile rheumatoid arthritis, psoriatic arthritis, Reiter syndrome, Gonorrheal arthritis, Polymyalgia rheumatica. I hope it helps. Now let's get started. In history, the onset of symptoms started whether days, or weeks, or months ago. Any presence of morning stiffness. This differentiates between the inflammatory conditions, example rheumatoid arthritis and ankylosing spondylitis, versus non-inflammatory condition, example osteoarthritis. Whether there is pain with activity or rest. Single or multiple joint involvement, symmetrically or asymmetrically involved, the location of joints involvement. This figure shows a summary of history. For the history of rheumatoid arthritis, the onset usually weeks, associated with morning stiffness. The pain duration is usually more than 30 minutes up to hours. Pain with activity and a lot or multiple or systemic joints involved, and proximal finger joint are mostly involved in rheumatoid arthritis. For septic arthritis, it is acute onset within days, no morning stiffness, constant pain, and especially pain with activity. Really, the number of joints is only one, sometimes can be more. For degenerative joint disease, the onset usually months, and the morning stiffness is less than 30 minutes. The pain duration minutes. And sometimes it occurs with activity or at rest. And the number of joints involved are variable, and the finger involved is distal. For physical examination, start off with inspection, where the presence of muscle wasting indicate a chronic disease, example rheumatoid arthritis, palpation or feel, any fever or increase in temperature that will lead to septic arthritis, tenderness and increase in warmth throughout inflammatory conditions, any presence of any effusion, that means fluid in the joint. Then move. Assess the range of movement. Severe guarding against joint motion, always associated with septic condition. This figure summarizes the examination between the rheumatoid arthritis, septic arthritis, and degenerative joint disease. For rheumatoid arthritis, patient may or may not have fever, significant muscle wasting, there is synovial tenderness, there is increase in warmth and effusion, reduced range of motion. In septic arthritis, patient will have fever and synovial tenderness with increased warmth and effusion, significant reduced range of motion. For degenerative joint disease, no fever, there is muscle wasting. Sometimes there is or there is not a synovial tenderness, no warmth, minimal effusion, and just reduced range of motion. For radiological investigation, look for signs of periarticular soft tissue swelling, joint effusion, osteopenia, joint space narrowing, periarticular erosion, joint subluxation, and articular cartilage or bone destruction. Inflammatory example, rheumatoid arthritis or septic arthritis. Marginal osteophyte, subchondral cyst, joint space narrowing, and subchondral sclerosis leads to osteoarthritis. Finding: a weight-bearing knee radiograph shows a joint space narrowing is the best to help diagnosis. Again, this figure shows a summary of radiological finding. For rheumatoid arthritis, for early changes, there is a periarticular soft tissue swelling, periarticular osteoporosis. For late changes, there is a joint space narrowing, periarticular erosion, articular cartilage and bone destruction, joint subluxation secondary to ligamentous involvement. For septic arthritis, there is a joint effusion, and late changes is articular cartilage and bone destruction. For degenerative joint disease, early usually joint space narrowing and marginal osteophyte. Late, we can see a subchondral sclerosis and subcortical cyst, marginal osteophyte. For blood investigation, these include full blood count, especially the differential count. Neutrophil will be raised in a bacterial infection. Septic parameter, especially erythrocyte sedimentation rate (ESR), C-reactive protein (CRP). Other blood investigation that helps in confirming certain diagnoses, example uric acid, rheumatic factor RF, and anti-citrullineated protein antibody ACPA for rheumatoid arthritis diagnosis. For synovial fluid examination, synovial fluid analysis involves assessing the following: appearance, the color, clot, presence or absence of clot, viscosity, the glucose compared with serum glucose, cell count per cubic millimeter, differential cell count, the type of crystal that might be present in the joint fluid aspirate as evaluated under a polarizing light microscope, gram stain and synovial fluid culture, the aerobic, anaerobic, fungal and acid-fast bacilli. This figure shows the synovial fluid analysis. So, in a non-inflammatory, the color will be transparent, high viscosity, negative gram staining, negative bacterial culture, leukocyte is low, neutrophil is low, and no crystal. For rheumatoid arthritis, usually is translucent or purulent in color, low viscosity, negative gram staining and bacterial culture, the leukocyte count is low, and negative crystal. For gout or pseudogout, translucent or purulent color, low viscosity, and negative gram stain and bacterial culture. The leukocyte counts and neutrophil also low, but there is a positive crystal present. For septic arthritis, purulent in color, variable in viscosity, positive in gram staining and bacterial culture. Of course, the leukocyte count and the neutrophil count will be raised, negative for crystal. For hemorrhagic aspiration, bloody in color, variable viscosity, gram stain and bacterial culture will be positive, with leukocyte count and neutrophil will be within or not raised, negative for crystal. The differential diagnosis of acute non-traumatic pain include, I'm doing a summary. Number 1, rheumatoid arthritis. The history, joint and tendon involvement that becomes more symmetric as the disease progresses. Examination will show a synovial thickening, joint tenderness, subcutaneous nodules, weakness associated with muscle wasting, and due to systemic disease itself. A. For seropositive rheumatoid arthritis, usually in female, symmetric joint and tendon involvement. There is synovial thickening, joint inflammation, nodules, weakness, systemic reaction, erosion on X-ray. Rheumatic factor is positive. For B. Seronegative rheumatoid arthritis is either sex, symmetric joint and tendon involvement, joint inflammation, little or no systemic reaction, usually no erosion radiographically, and rheumatic factor is absent. This figure shows the hand deformity in rheumatoid arthritis. You can see there is a Z deformity, bottleneck deformity, metacarpophalangeal joint subluxation, and ulnar deviation. B. Collagen. A. Include systemic lupus erythematosus SLE. In female, symmetric joint distribution, identical to rheumatoid arthritis, no erosion radiographically, non-inflammatory joint fluid with good viscosity. Multiple systemic involvement, mucosal lesion, rash, renal involvement, neurologic disorders, blood disorders, example leukopenia, immunologic reaction, photosensitivity, serositis, that means pleurisy, or pericarditis. B. Scleroderma. Presence of tight skin, Raynaud's phenomenon, resorption of digits, dysphagia, constipation, lung, heart or kidney involvement, symmetric tendon contracture, little to no synovial thickening. Radiographically, you can see calcinosis circumscripta, positive ANA with speckles or nucleolar pattern. C. Polymyositis, dermatomyositis. Patient present with proximal muscle weakness, pelvic and pectoral girdles pain, tender muscles, skin changes, typical nail and knuckle pack erythema, systemic joint involvement, electromyographic evidence of combined myopathic and denervation pattern, abnormal muscle biopsy, elevated creatinine phosphokinase. D. Mixed connective tissue disease, swollen hands, Raynaud's phenomenon, tight skin, symmetric joint and tendon involvement, possible joint erosion radiographically, positive ulnar speckle pattern, anti-ribonucleoprotein antibody increase, good response to corticosteroid therapy. E. Polyarthritis nodosa, symmetric involvement, diverse clinical features of systemic disease, histologic diagnosis. For 3, rheumatic fever in a young patient 20 to 40 years old, present with sore throat due to group A streptococci, presence with migratory arthritis, rash, heart or pericardial involvement, elevated anti-streptolysin or titers, migratory joint inflammation, responds well to aspirin. Number 4, juvenile rheumatoid arthritis. Systemic joint involvement, rash, fever, no rheumatic factor, radiographic periostitis, Erosions can be late and can recur in adults. Number 5. Psoriatic arthritis. Asymmetric boggy joint and tendon swelling. Skin or nail lesion may not be prominent or may follow arthritis. DIP joints might be prominently involved. Radiologic periostitis or erosion. Number 6. Reiter syndrome. Male urethritis, iritis, conjunctivitis, asymmetric joints in lower extremity, non-painful mucous membrane, ulcerative lesion, and weight loss. Number 7. Gonorrheal arthritis. Migratory arthritis or tenosynovitis in one or more joints or tendons, either sex, focus on urethra, female genitourinary tract, rectum, oropharynx, skin lesions, vesicles, gram-negative diplococci on smear. Positive culture at primary site, blood or joint fluid. Number 8. Polymyalgia rheumatica. In elderly patient more than 50 years old, symmetric pelvic pain, morning stiffness of long duration, fatigue, weight loss, joints involved include shoulders, sternoclavicular joints, the knees. ESR is markedly elevated alkaline phosphatase. Number 9. Crystal induced. A. Gout, symmetric arthritis, flexion contracture, prior history of acute attacks, tophi, joint swelling, hyperuricemia, monosodium urate monohydrate crystal in joint fluid. B. Pseudogout, symmetric arthritis, involve metacarpophalangeal joint, the wrist, the elbow, the shoulder, the ankle, knee and hips. Prior acute attacks sometimes present, joint inflammation. Calcium pyrophosphate dehydrate crystal in joint fluid. Please remember, yay! We have reached to the end of this video. I will cover regarding the non-inflammatory joint pain in another video. See you in the next one. Take care and bye.